we don't have a lab test to verify or not verify pain. Pain is either going to be believed or not believed. And I think it's underappreciated what those often debilitating episodes have on one's self-determination.
Hey, Sickle family. I'm Wumi Bakare.
I'm Christelle Solomon.
With a special guest appearance from Dima Hendricks.
And we would like to welcome you to the Through the Genes podcast,
where we talk about living,
healing,
recovering,
and exploring transformative therapies for sickle cell disease.
We will also talk about our individual journeys and the bond that we have built as sickle cell sisters. Hey, Sickle family. Welcome to another episode of the Through the Genes podcast. I am your gracious host, Wumi Bakare, and today I have my fantastic co-host, Christelle.
Hello, Sickle fam. So excited to be together today.
Today we have a fantastic guest who I'll let Christelle introduce because they have a long-standing relationship.
Awesome. Where I am so excited, y'all. I am so excited because we're joined today by a very special guest who's had a huge impact on my life personally, my very own transplant doctor. So I'd like to introduce Dr. Mark Walters. He's a hematologist-oncologist, an expert in sickle cell disease and transformative therapies in sickle cell disease, including gene therapy and transplantation. Dr. Walters is a provider who truly cares for his patients and wants to see the best for the sickle cell community. And so I couldn't be more thrilled to have him on our call today. Dr. Walters, welcome.
Thanks so much.
So for viewers who are interested in how does a sickle cell patient maintain their health so they are a perfect candidate for cell and gene-based therapies, then this is the episode for you. Christelle, you can tell that there's a lot of fondness between you and Dr. Walters, and it's really exciting to see because as patients, we lean heavily on our providers to guide us through what probably is for many of us the most challenging journey we've ever been on. There are lots of windy roads, and so having a provider that truly cares, but also is able to articulate everything you're going through during each process and reassure you that, you're both on the journey together. There are no words to suffice how grateful we are to our providers for all of the roles they play in our lives. Dr. Walters, Christelle and I are post-stem cell transplant recipients. And oftentimes, because these conversations around cell and gene-based therapies are relatively new, specifically gene therapy, many patients don't understand what it takes to meet the eligibility criteria to participate in these transformative therapies. Can you help us understand what pre-treatment health requirements do we have to consider before embarking on the gene and cell-based therapies process?
Yeah, so it's an important topic to understand. And the basis is that, like I mentioned, this is an intensive treatment that has significant risks associated with it. So when it was being developed, the notion was that one should have severe disease to balance out the risk and benefit. So if it's successful, if a person is having a lot of trouble with their sickle cell disease, then the benefit would be elimination of those problems. And the risk, of course, is getting through high-dose chemotherapy and all the other complications, both in the long term and short term, that might happen. So currently, payers, that is insurance providers for the approved treatments, have relied on the same eligibility criteria we used in the clinical trials that developed and led to their approval. And for the mainstay is painful episodes. So one must have 2 or more painful episodes per year in the 2 years leading up to the treatment in the clinical trial. And these painful episodes could be acute chest syndrome, it could be pain, but it must be treated in a hospital setting, and generally with the kind of treatment we give in the hospital setting: analgesics, opioids, fluids, so forth. So that's really, in a nutshell, the basis. So 2 significant what we call vaso-occlusive episodes, or VOEs, in the 2 years prior to enrollment. Now, one of the treatments, Casgevy, that raises the fetal hemoglobin, is not a proven way to prevent stroke in sickle cell disease. So individuals who've had a stroke are generally excluded. And Now, I think that should shift, and I think it will, but that's where we are right now. And the other thing that comes up a lot is what about my genotype? Is SC, S thalassemia, is that eligible? Well, these trials were really limited, restricted to persons who had the most common form of sickle cell disease, the hemoglobin S, or S beta thalassemia, beta 0, that is, and that is most of the time the most severe genotype. Some persons who have SC genotype, sickle C disease, have just as severe disease as anyone with SS. And it seems to me they would also benefit from this. But again, that's uncharted area still. So you might find that you're excluded, unfortunately, if you have SC disease.
I want to ask this question because we get it so often in the community, and that is, when the clinical trials were taking place, is there a reason why there was preference for HBSS? I understand that, again, every patient has a unique experience with sickle cell disease, but piggybacking off of what you just shared, I don't think if a patient that has SC is showing progressive sickle cell VOEs over time and some organ damage, why wouldn't they be considered? Is there anything during the treatment process that affects the type of sickle cell disease the patient has that makes researchers and scientists lean more towards focusing on HBSS?
Well, this has a peculiar answer, which is when we started the clinical trial for Lovo-cel, which is now the commercial product Lyfgenia, we actually had very broad eligibility along the lines that you just described, and really followed the traditional eligibility that we use for bone marrow transplantation, which encompassed 6 or 7 different problems that the persons with this disorder develop. And, when you're developing a new treatment and the FDA is regulating it, they have a strong say in how it's carried out. And the FDA was very clear, and I don't, on one level, disagree with this, which is, if pain is the hallmark of this disorder, which it is, then they reasoned that if you go through this kind of intensive treatment, your pain should be eliminated. And so that was the study design they have insisted on, that the treatment outcome should be transformative in that it eliminates pain completely. Now that's, in retrospect, short-sighted, because first of all, it doesn't eliminate pain for everybody. Some people have lingering pain for months after the treatment, although it eventually gets better. So that's a problem. And you're absolutely right. If you have other complications, other organ impairments associated with sickle cell disease, either of these treatments should stabilize that, should make it better. So I'm, like you, struggling with that a bit.
I'm so glad that you brought up HBSC, Mumi, and your answer, Dr. Walters, because I remember when I was sort of considering what my treatment options would be outside of disease-modifying therapies like hydroxyurea and Adagveo, and I felt like I struggled to get providers to understand that my quality of life was low, my disease was severe, even though I had hemoglobin SC. And there were multiple conversations that I had with providers when it came to considering transplantation, where it was kind of like, well, your organs aren't completely messed up yet, and you're not quite dying yet. You're still functioning in everyday life. You don't need a transplant. And so for me, I really struggled in that journey of trying to get to the point of transplantation, even after I found out that my brother was a perfect 12 out of 12 HLA match, because I felt like there was like a struggle to see my problems as human. And that's why I'm very grateful for Dr. Walters. And so I wanted to ask you, Dr. Walters, how do you balance, how do you evaluate whether someone is fit for transplant or gene therapy? And how do you balance that, okay, we want to make sure that this is severe enough to warrant a treatment that has so many risks and could potentially not even fix the problem that you're intending to fix, but also not waiting so long that now you become ineligible because you're so unhealthy you can't tolerate such a serious treatment? How do you balance that?
I am so glad you asked that question, because it illustrates the problem of implicit bias among healthcare providers of persons with this disorder, because the hallmark is pain, and we don't have a lab test to verify or not verify pain. Pain is either that report is either going to be believed or not believed. And I think it's underappreciated what those often debilitating episodes have on one's self-determination. So as I recall, Christelle, and I'm not going to go into the details of this, but I don't think I'm revealing anything surprising, is that your career arc, because of your sickle cell disease, was not going the direction you wanted it to go. And in fact, it was hopelessly stalled, I would say. And so from my point of view, the pain you were experiencing was so debilitating, and your desire to be free of that warranted consideration of a transformative therapy. Now, you're not going to find that in a textbook or in a paper as, oh, Christelle's eligibility criterion. But it's the kind of conversation you have to have with through consultation with the transplant doctors, who hopefully will see through, what really should be the driving motivations. So that's one illustration of how I approach it. And a lot of others like you satisfy, in my mind, the criteria, but that's not universal among all healthcare providers. Honestly, who are they to say that your disease is severe or not? Unless they're living your life, we have to rely on your report about it. And so that's really, I think, the key to access to get in the door. Now, there are lots of other barriers once you get through that door, but that's something that I would like to relay to the providers.
Thank you for sharing that, because I think so many patients listening to this podcast will feel seen in you saying that, because I just know so many warriors who are having a really difficult time with their sickle cell diagnosis. And there's the initial trepidation of, since I don't meet the eligibility criteria, I don't need to explore this further. I now start to have to come to terms with the fact that I'm going to live with severe chronic pain and live with all of the debilitating complications like, acute chest syndrome and avascular necrosis. And so you sharing that, I really hope that gives people a sense of hope, that it may be a conversation of meeting a provider who is willing to support you in your own choice to want to embark on this journey. Now, for many of us, I know for me, I went through a slew of health screenings prior to transplant. I had to do, the 6-minute walk. I had to go through mental health to make sure I was, again, in the right state of mind to embark on this journey. Can you talk to us? And if you don't mind, can you break into a little bit more detail some of those tests that occur prior to treatment, and why is it important to look at those those function tests?
Yeah. So there are two reasons to do all those tests. First and foremost, they help us ensure that it would be safe to proceed. Because if let's say you have significant mental health issues that might get in the way of remembering to take all your medications on time, if you skip your medications after a transplant, that becomes a life-threatening problem. And so we can't do that. That just isn't ethical to put someone at risk. So you're right. We do a number of organ assessments to make sure that your body and you are strong enough to get through the treatment safely. The second reason why we do them is we want to compare how you were before the treatment to how you are after the treatment. And some of that is research, but some of it is just proving to ourselves that the treatment was successful, that your organs are spared of ongoing damage, that your pain is better, that your quality of life has improved, and so forth and so on.
I know before I embarked on transplant, it was 3 days of back-to-back tests that at some point I was like, okay, I haven't even gotten to the prize. I can't even see the prize in sight. They're making me jump through so many hoops. So can you explain, what is the importance of the 6-minute walk test? Why are we doing MRI scans and making sure we're taking a look at the heart and the brain and the liver and the kidneys and the lungs? Why are we checking? Because I do recognize that they have to make sure you are healthy enough that the treatment is not going to further damage your body. But I would imagine that there are things you are intentionally looking at. Like for me, I shared this with Christelle. I had to go through to see a dentist because the providers were like, that could be an area of infection when you embark on the conditioning regimen. So why all of those tests?
I'm happy to get into the details because that's the world I live in. So you're right. So we'll do a heart test. The idea is that We want to make sure the heart is pumping, the stroke volume, the ejection fraction, the contractility of the heart. Those are medical terms, I know, but just the strength of the heart is strong enough so that if you were to get a serious infection and a condition called sepsis, which we know lowers the blood pressure and puts pressure on the heart to escalate its work, your heart is able to do that. And then in that way you can ride out the storm, if you will, and recover from a serious infection. Lungs are kind of the same story. We know that the lung in sickle cell disease is prone to certain kinds of damage. We want to see the extent of that damage, because if it exceeds a certain limit, then we worry about it. If you were to get a pneumonia in the course of the treatment, which is an infection complication, that you would be able to get through that safely, and that you'd have enough reserve in your lungs to navigate through that and to recover. Same with the kidneys, same with the liver. The brain, we often want to understand because we want to show that that is protected from additional damage. So we typically get one before the treatment, brain MRI, and then one 2 years later. We might get an MRI of your liver if you have an iron overload because you've had a lot of transfusions. That iron is not going anywhere, even if the treatment is successful. So we have to have a way of quantitating how much iron's in your liver, and then what does it take to remove it after the treatment. Now, that removal will be permanent because you won't need transfusions anymore, but that helps guide how long we need to do that. So a lot of it is related to safety and also ongoing monitoring after you get the treatment.
Thanks for those details. I think, like Wumi was saying, sometimes I think considering, I just want to bring a little bit of adding a little context, just thinking about the history of medicine when it comes to Black people in the U.S. and clinical trials. And I think there's a baseline. I will speak for my family. I know my mom says, I don't trust all these tests. What are they doing with this information? But to hear that every test has a purpose, and the purpose is actually for our safety, it brings so much more color to the picture and context to help us understand, okay, why is it important? And I think I'm hoping providers will walk away on this call too, that it's such a delicate balance of understanding organ damage and how healthy are you to receive this treatment, but when is it warranted to get started on that? So thank you for those details, because it really brings some additional context. And I wanted to ask just very practically, as a warrior, let's say I'm Christelle and I'm coming to you, but I'm considering transformative therapy maybe a year down the line or 2 years down the line, or maybe it's not an option for me right now. How can we as warriors stay healthy enough to pursue that treatment, maybe not today or tomorrow, but in a year? And I mean, given that we know that even if I decide I wanted to do gene therapy today, I still have to sign consent, do all the eligibility, insurance authorizations, stem cell collection, apheresis. There's so much that leads up to that point. How can a sickle cell warrior stay healthy while waiting for transformative therapy?
Yeah, I think that's so important. It really relies on having access to comprehensive, competent care, so that you have somebody monitoring your health, and if a new problem arises, having it addressed immediately. There are disease-modifying therapies that you mentioned, Christelle. Making use of those will often improve protection to organ damage and also protect against getting really ill and with something like acute chest syndrome. So adherence to the treatment program that your provider sets up for you, and then, like I said, just ongoing monitoring of your health. And every year there are certain tests that every person should have. Don't delay those. Please show up for your appointments so that the team taking care of you can monitor that. And those are the best ways. And it seems so simple, right? This is something anyone should have access to. And, it's very shocking, particularly among adults in our communities, how few actually have access to good care and sickle cell disease competent care. So you may find that you have to seek that out and you have to be aggressive about it. And it may mean traveling some distance to be able to do that. But I would urge you, if you are seriously considering this, that is an investment in time and energy and effort worth making.
I want to ask this question because I've always been curious, and I don't think anyone has really been able to give me a straight answer, which is, oftentimes when you are embarking on gene therapy or transplant, providers will stop hydroxyurea before you go through the conditioning regimen, and instead, to maintain your health and keep you, VOC free, they will do exchange transfusions. Why do we stop hydroxyurea? That's my first question. Then my second question is also, there are patients that, even though the standard of care treatment is hydroxyurea, they haven't benefited from hydroxyurea. I am a prime example. I was on it for over a decade and I didn't get the benefits that some of my peers are getting. So instead, they are on crizanlizumab, they're on L-glutamine, they're on voxelotor. Can you explain why researchers prefer patients that were on hydroxyurea as a standard of care treatment as opposed to the other disease modifying therapies?
So the hydroxyurea that we stop before, let's say, a stem cell collection is because of the effect the hydroxyurea has on the bone marrow where the blood cells are made and on the health of the stem cells that we're trying to collect. So one of the reasons you have your blood counts checked every 2 weeks is that hydroxyurea can lower the blood counts and warrant stopping it actually until they recover. And the idea here is that you want to stop the hydroxyurea for a period of time before you do the stem cell collection to ensure you get the highest quality, healthy stem cells collected. Now, if there's going to be a long delay before actually reinfusing the stem cells after they've been manufactured and edited by the procedure in the manufacturing suite, perfectly fine to resume the hydroxyurea in that interval. But in at least the 2 to 3 months, sometimes it's longer, sometimes it takes us 6 months to actually collect enough stem cells to get to the manufacturing goal, then that's how long we need to stop the hydroxyurea. The other thing is, particularly in males, if you're going to do a sperm collection for cryopreservation, to have that option, then the hydroxyurea lowers the sperm count. So that's another reason why we will stop the hydroxyurea for several months to be able to get a good collection. And then we can resume it afterwards if there's time to do that. The hydroxyurea, it is not 100% effective. There are about a quarter of patients actually who have almost no response to it. And I'm not sure why, but this has been tracked over time. And so, yeah, I agree with the approach that if you're not getting a benefit, you should move on to something else that might be more effective. But in total, if you look at 100 persons getting hydroxyurea, it will reduce your pain by 50%. It will reduce the risk of acute chest syndrome by at least 50%, and it will extend lifespan. So on the whole, there's a very strong benefit, which is why we try to start it in every person by 9 months of age, as that's feasible to do.
Thank you. I appreciate your response, because for me, I never understood. I was like, well, why would you stop something that was helping me? And instead, because for someone like me, I have iron overload, particularly in my heart and my pancreas. And I've been on chelation for the past 5.5 years, getting 500 cc's dumped every 2 weeks, taken out, because I don't tolerate the Janadu or Xjade. I don't tolerate the oral medication, so it has to be done that way. My hematologist is always saying, slow and steady wins the race. It's not a sprint, it's a marathon. And so for me as a patient, I've always been curious as to why that process happens. But now that you've explained that for men, it impacts fertility, but not only that, it impacts the quality of stem cells, then it makes sense to stop the medication if it does have adverse effects like that.
Okay, so Dr. Walters, in the pre-treatment process, can you help us understand, are there any specific complications that you're concerned about when you're monitoring in the screening process and before the patient actually receives any conditioning regimen, before they're hospitalized? Are there any issues that you're looking for in particular that you want to avoid or make sure are being managed well before the patient starts treatment?
Yes. So, and this is specifically regarding the gene therapy, gene editing treatments with Casgevy and Lyfgenia. When we mobilize and then collect stem cells, we give a medication, an injection under the skin called plerixafor. It's given about 4 or 5 hours before we start the collection, and it will raise the white blood cell count. And we know that a high white count, particularly with sticky white blood cells, can lead to pain. And so one of the things we monitor for is a pain event after or during the collection. Happens about 10% of the time and can extend the hospitalization. we want everything, all that inflammation caused by the pain and the blockage of blood flow and blood vessels. We want all that to settle down before we begin a collection. We also want that completely settled down before we embark upon the reinfusion and the high dose chemotherapy, because the last thing you need is to have an event like that in the middle of your treatment. It already, the treatment itself will elicit pain, and then you don't need a sickle cell pain. So we try to keep I like to keep the hemoglobin S less than 30% in the lead-in before all that, and to keep you pain-free. If a person happens to have a painful event, gets hospitalized a couple weeks before the planned infusion of the gene therapy, gene edited cells, I'll delay it. I'll postpone it for a week, couple of weeks, or even a month until everything settles down again, the inflammation goes away. So those are some of the things that we monitor and try to avoid leading into into. Wendy said something very interesting. In many persons, hydroxyurea is better than exchange transfusions at preventing pain. And so we struggle with how best to do that.
Okay. I'm curious about lifestyle. My brother was my donor, and 6 months before he donated his stem cell, he completely cut out meat, cut out alcohol, because he was like, I want to give you my very best stem cells, so we make sure this works. I don't know if that impacts it, but we let him believe it did. So I'm curious to know, because for a lot of warriors, because our disease is such a burden, meaning it's blood, and blood is everywhere. We're not just talking about like organ issues, we're also talking about like bone issues and nerve issues. It's in our best interest to try and maintain a healthy lifestyle, but not everybody does. That's just their life. And so what type of lifestyle should people endeavor to try prior to embarking on the transformative therapy process? Because I know for a fact, smoking, not a great idea for anyone. But when you add living with a chronic illness like sickle cell disease, it's definitely not a good idea. Neither is alcohol, because it dehydrates you. And for us, we need more fluids to kind of keep our sickled cells moving. So what type of lifestyle does someone need to adopt before and after a transformative therapy?
Yeah, I think you've hit on it. I don't have very much more to add. I will say that vaping, that is so popular right now, is particularly dangerous after the treatment.
Okay.
We had, unfortunately, there was one person in another clinical trial in an experimental treatment that's under development who apparently was vaping, got quite sick, and died of a lung complication after the transplant. So now that we know about this possibility of that association, I'm finding out if anyone is, I mean, I never asked before, to be honest. So I am asking now. And if you do vape, then I make sure you commit to stopping. So it's things like that you may not even think of it being an issue. Just bring up your habits. Let's be transparent about it and make sure that either it's safe or not safe to do, and that we decide together how to handle that.
Because Crystal and I, we volley back and forth about this. Post-treatment, the way our GI tract is set up is not the same as prior to the transplant. And so for me now, on the other side with sickle cell, the only way I could get all of those meds down was with soda. And now if I take soda or Capri Sun, my body is like, girl, don't do this. Why are you doing this to yourself? Not only am I having joint pain, but then, it just feels like my intestines are twisting on each other. And so now I've had to kind of introduce more, almost like a pescatarian diet, a lot of grains, a lot of like seeds, nuts, because it's significantly better for me post-treatment. And so I always wish and hoped that I had spoken to a nutritionist prior to embarking on the process, so that I had strategically started weaning myself off all of these foods that we all know they're bad, but we're like, it's a good snack. It's soda. I need a little bit of a sugar high. That, at the end of the day, tend not to be good for us holistically. So thank you for clarifying and sharing that. Like vaping, guys, I don't think vaping is a good idea. Let's just put it down. I know these companies are making them colorful with different flavors, but it's not worth it. It really isn't.
Yeah, I'm glad you brought that up, because as you know, in the course of going through the transplant, we use a lot of antibiotics, and some of them are really completely alter the microbiome. So that's the collection. It's a diverse collection of bacteria that live and help our intestinal health. And what some of these strains do is they lay down a thin layer of mucus over the lining of the intestines and protect it from invasion by other nasty bacteria or just danger in the environment. So you can imagine what happened to you is that your microbiome got completely altered, which is why you're experiencing all these changes. And we don't really know how to restore yet the microbiome. It's almost like maybe one day we'll be getting a sample of those bacteria that live in that area of your body, and then giving them back after the treatment to kind of repopulate with the healthy group of bacteria that should be living in there, help with digestion and keeping your gut health safe. So, but diet is a big part of it. Like one thing I always like to bring up, which the children hate on my service, is broccoli. Broccoli really promotes, growth of these what I call commensal anaerobes, so the ones that lay down the mucus. So eat your broccoli, and don't go to Panda Express for heaven's sakes. Yeah, eat healthy, fresh food if you can. That's hard to do. I know. I'm not very good at it either.
It's funny you mentioned broccoli because I just bought broccolini and broccoli yesterday. It's one of my favorite vegetables, although how I prepare it sometimes may defeat the purpose of the actual health benefits, but I call them broccoli chips. And so what I do is I put sesame oil and the Green Goddess seasoning from Trader Joe's, or just use salt and pepper, put it in the air fryer. They come out so crunchy. It's literally like a bag of chips. I'm like, this is dangerous. I'm sure it's not good. It tastes too good to be good for you anymore. Oh man, I know we're running out of time, but I have a question that I just can't help but ask. And this was something that I struggled to navigate, and I was getting a lot of help from the therapy resources at UCSF where I got the treatment, and also the PT team. But can you tell us a little bit about how to navigate post-transplant? Because in my mind, I'm like, I know I'm not sickling anymore, right? That's my thought process. Like, I'm not sickling at the rate that I was sickling before. I still have some sickle cells because I have sickle cell trait. But I'm like, I want to go for a walk and I want to exercise, but I'm so tired. And I also don't want to trigger any pain. And my body still kind of remembered some of the triggers from before. So even though I'm not sickling, if I'm outside in the cold for a long time, I would still get pain. And so how does one manage this like new body and new life post-transplant when it comes to trying to build your strength because you have the opportunity to maybe do a few more things that would have otherwise ended you up in the hospital? But how do you also not overdo it in that season post-transplant?
I wish I had a good answer. I'm still ignorant of the pain pathways and how to remodel those, but we do know that the nociceptic, the nociplastic, those are medical terms to explain what part of the nervous system in our peripheral nerves, let's say, sense pain. And those get completely remodeled in sickle cell disease. If you're a type of person who has pain on most, if not all days, is taking opioids almost every day, if not every day, and have been that way for months and years, that pain and the sensing of it is not eliminated immediately by a successful transformative treatment, because the nerves have to remodel, and that's not a fast process. So I'm not surprised that if you try to do things that your red blood cells will perfectly happily support, that your pain system is not up to speed to do it. And so and one really famous study I like to quote in the National Institutes of Health, a clinical trial of adults who got matched sibling transplants. Half the patients, depending on the type of chronic pain they were classified to have, were still receiving opioids a year after their successful transplant. So that just gives you a sense of how long it takes to resolve those issues. So I wish I could explain how to speed that process up. I wish I understood it better. I just say the words. I'm not a pain expert, but that's something that is intensely studied right now, and I hope we'll make some progress.
Dr. Walters, I want to pose this final question to you before we do our rapid fire questions at the end, which is the fun little game we like to play so that we can peek behind Dr. Walters and get to know Mark. You are a pediatric hematologist. How do you help children in particular navigate these complex transformative therapies? Because I've shared personally with Christelle that I'm grateful I had mine when I was in my early 30s, because if I was younger, I wouldn't have the mental capacity to be able to tell myself when I'm experiencing chronic pain that, sweetheart, you've gone through a treatment. It feels like pain. Just take some ibuprofen, use some distraction techniques, and you will be fine. But as a child, you're not equipped. Your brain isn't fully developed till you're 25. You're not equipped with the language and the tools to be able to navigate emotional challenges that could show up while you're going through these transformative treatments. So how do you as a provider help kids cope with these complex processes?
Yeah, the kids are pretty easy. They're so resilient, and if they're feeling well, they want to play, and when they're not, they don't. I mean, they don't play games. I mean, they play games, but not mind games. So actually, it's delightful to bring a child through it because they will have down days. That's really clear, and we do what we can to make them comfortable. And then when they're feeling good, they're back to playing and being a kid. And what's really interesting is that when we do our reunions and we meet with the now adolescent adult survivors who went through that as really young children, they have no recollection of either life before sickle cell disease or the treatment itself. So wouldn't it be wonderful if we could intervene with a transformative treatment that was safe enough to give to all children? And then we could eliminate this darn disease. So that's really the goal, is to eliminate the problem before it becomes a problem. And I mentioned justice. So that's the path we're on. The path to justice is having a safe, effective treatment that we can give before all these problems and chronic pain develop.
That is pretty mind-blowing to me. That process, that I don't know what I was expecting. I know we're trying to transition into our fun little time, but I just want to comment on what you just said. I think I just wasn't expecting to hear that. It almost seems like in the young childhood, there's a resiliency and maybe just a lack of recollection, because I feel like we've lived 30 years with our conditions. We remember
Yeah, of course.
all the trauma that we went through beforehand and the roller coaster of going through treatment. And so I guess it's a bit of encouragement.
Yeah.
I give credit to that answer to Jimmy Olivier, who is a warrior who had a treatment, a gene therapy treatment. And he said, I'll never forget this. He said, I want the future of sickle cell disease to be different from what I went through. That those children shouldn't have to go through what I went through. And that really sparked inspiration in me.
Shout out Jimmy, who's one of our favorite advocates, our CRISPR evangelist, and just a fantastic human all around, who continues, even though we're friends, continues to inspire me every time we have an opportunity to chat. So we're going to switch gears a little bit and hit some rapid fire questions. Dr. Walters, we're giving you 2 seconds to respond.
Just two.
Just 2. And we're being generous. Usually we would give 1, but because we respect you, we're giving 2. Here we go.
If you were an element on the periodic table, what element would you be and why?
Oh, I would definitely be neon because, I like to glow in the dark.
That's a good one.
That's a really good one. I thought we were going to say like oxygen because I like it. I thought it was going to be something easy peasy lemon squeezy. But you see, this is why there are layers to Dr. Walters that we have to uncover.
I love that.
If you were a hematologist-oncologist saving children's lives, what would you be doing?
I'd be doing what I'm doing now, I think. Focusing on transformative treatments.
Okay. So basically, your life, you live and breathe medicine. You are destined to be a provider.
I think so, yeah.
Okay.
I didn't know exactly what I would be doing, but I knew it would be something like this.
That's beautiful. Okay, now our last one. What is one thing that makes you smile no matter how hard the day is?
Pictures of the grandchildren. That's easy. I have 3 of them right here next to me. So yeah, I look over there a lot. When you get that nasty email or you get off the phone, just look at that.
brings you back to center.
Yeah.
It does, doesn't it? Yes.
All right. Thank you, Dr. Walters, for just giving us really valuable insights today. I think everything you shared are things that I think patients, caregivers in particular, really want to know, because this isn't a journey of just the individual. Sickle cell impacts the entire family unit, and embarking on the transformative therapy process, you need a primary caregiver. And so you lending your knowledge and sharing with us insights about how to effectively maintain eligibility so you can embark and see through these transformative therapies has been really, really encouraging.
Thanks for sharing your knowledge and bringing the perspective that will be relatable and practical for providers, but also allows warriors to feel seen. And that element is, I think, that's what takes a provider to the next level, is the extra touch and care. So I just want to say thank you. And to our listeners, keep staying engaged. Make sure to tune in, stay informed, ask us questions in our comment section. Every time you listen to an episode or we drop a teaser, feel free to let us know your thoughts and engage with us that way, so that we can stay progressing and moving forward and addressing the things that you as community members actually care about.
Thanks for having me.
Of course, this was fantastic. Now, if you loved this episode, but you have a question for Dr. Walters, please go ahead and send those questions in. We will get them directly to him, and we might not be able to hop on a podcast and let you know the answer, but we'll get you an answer indeed. So again, don't forget to like, share, subscribe, comment, reshare, repost on all social media platforms. And don't forget to visit www.throughthegenes.com for all the latest news on upcoming episodes and to purchase your own Looking Good in My Jeans t-shirt. Signing off, Wumi Bakari and Krista.
And Christelle Solomon.
Bye. This show is brought to you by Beam Therapeutics, Synthago, and Kamau Therapeutics, with support from the UCSF Sickle Cell Center of Excellence, Through the Pain Inc., and Sickle Cell Prodigy.